Hi everyone. Today we'll discuss about the treatment of appendicitis. First is the non-operative management. So maintain hydration of the patient by giving IV fluids and keep the patient nil per oral and start them on broad spectrum IV antibiotics covering both gram-negative aerobes and anaerobes. Since appendicitis is always a polymicrobial infection, the common organisms isolated are E. coli, bacteroids, enterococcus, Pseudomonas, Klebsiella, etc. So any patient more than 40 years should be evaluated for malignancy. If a mass is palpated in right iliac fossa, then go for a conservative management, since when you try to operate these kind of patients, there is more harm than the benefit. So the management of appendicular mass is called as Ochsner-Sharon's regimen. So used when the inflammation is localized and the surgery is difficult, as it can injure the cecum and the ileal loops and may lead to fecal fistula. So keep the patient nil per oral, monitor pulse rate, temperature every fourth hourly, and monitor the size of the mass and the bowel movements. So if there is a decrease in the size of the mass and there's no tachycardia, fever, that means the patient is responding to IV antibiotics and the infection is getting localized and there is no formation of abscess. Continue the same treatment and discharge the patient, and you can do interval appendicectomy after 6 weeks. So criteria for stopping conservative management: when you need to put a hold for this conservative management and patient needs a operative procedure, that is when there is increase in the heart rate and increased abdominal pain and increase in the size of the mass and there are no bowel movements, so go ahead with the operative procedure. So whenever, even though the patient has responded to your treatment, there is decrease in the tachycardia and there is no fever, pain has reduced, but the mass has not resolved. So what might be the reason? It could be carcinoma and Crohn's disease. So operative management come with a conventional appendicectomy. So the patient is placed in supine position under subarachnoid block. The incisions given are MacArthur's McBurney's incision. This is the most commonly used, and it is so the incision is placed, and this is the umbilicus and this is the anterior superior iliac spine. When you draw a line adjoining it, so divide it into 2/3 and 1/3 and place an incision perpendicular to the McBurney's point. When you open up the external oblique aponeurosis, you see the internal oblique muscle. So you always split these muscles rather than dividing it with the cautery. So Rutherford Morrison incision is cutting the internal oblique and the transversalis muscle, and Lance incision, it is placed 2 cm from the 2 cm below the umbilicus. It is centered from the mid-clavicular line and the mid-inguinal point. Mid-inguinal point is nothing but the point between the pubic symphysis and the anterior superior iliac spine. So this provides a better cosmetic purpose, but the difficulty is whenever you need to extend the incision or for the exposure is limited here. In doubt or there is a presence of obstruction, so go over lower midline incision. So what do you do in appendicectomy? So once you identify the appendix, so you have the appendix and you have the mesoappendix like this. So you start ligating the mesoappendix, dividing the mesoappendix and bear out the appendix and ligate the base of the appendix. Identify where it is entering the cecum. So I ligate the base of the appendix and take it off. So what is retrograde appendicectomy? Ligate the base first whenever you are not able to visualize the appendix tip properly, maybe because of the adhesion or it is in the retrocecal position. So you ligate the base first, followed by the dissection of rest of the appendix. So when it is completely retrocecal, So you need to divide the lateral peritoneal attachments of the cecum so that reflect the cecum medially, and you can see the posterior surface and you can identify the appendix. So there are situations where you can see normal appendix intraoperatively. The patient had classical features of appendicitis, but intraoperatively it looks normal. So then look for Meckel's diverticulitis. Examine 60 centimeter of the distal ileum. Look for any diverticulum is present or not, or terminal ileitis, or look for, in females, look for tubal or ovarian causes. In normal appearing appendix also, there could be some microscopic evidence of appendicitis. So the patient is having appendicular abscess, then the best thing is to insert a percutaneous drain, or called as a retroperitoneal drainage, retroperitoneal drainage to drain the abscess, give IV antibiotics, maintain hydration, and call the patient for appendicectomy after 6 weeks. Appendicitis in pregnant patient. So this is the most common non-obstetric surgical emergency in pregnant patients. So the patient comes with diffuse peritonitis. Then resuscitate the patient, give antibiotics and operative management, mainly the laparoscopic appendicectomy. So there is no diffuse peritonitis, go for USG. So other diagnosis treated accordingly. It could be some ovarian or uterine pathologies. If appendicitis is confirmed, go ahead with appendicectomy. The USG is not conclusive, then go for MRI. So MRI suggests appendicitis, go for appendicectomy. If it is not showing any kind of appendicitis changes, observe the patient. So if the patient improves with antibiotics and conservative management, discharge, and if the patient worsens, go for diagnostic laparoscopy. Post-operative complications of appendicectomy. So the wound infection is the most common, can vary from erythema to frank pus discharge from the wound site. So depending upon the amount of infection, so lay open the sutures, allow it to secondarily granulate, and go for secondary suturing. And it could be cause of intra-abdominal abscess. So drain the abscess by placing a pigtail. So there could be post-operative ileus. So that could be because of the immediate post-operative period, or it could be the presence of intra-abdominal abscess, or Reacher's hernia. Reacher's hernia is nothing but the circumference of the bowel. Circumference of the bowel gets obstructed at the port site. The next is the venous thromboembolism. So any abdominal surgery or pelvic surgery where the patient is not mobilized can land up in DVT of the lower limbs. So portal pyema is most important, that is pylophlebitis known as. It is most commonly seen in perforated appendicitis, causing septicemia in the portal venous system, and this septic emboli can reach the liver and cause multiple intrahepatic abscess. And fecal fistula, that is mainly seen in Crohn's disease, where the base of the appendix was not healthy and the surrounding cecum was also edematous and fragile, so they can give rise to fecal fistula. So post-operative adhesions, unlike any abdominal surgeries, they can also result in adhesions and can cause future intestinal obstruction. Thank you.